We're here today for another episode of Black Belt Lifestyle. I'm Dr. Pasquale Montesano, orthopedic surgeon, spine surgeon, wellness director, and Hoist Gracie Black Belt. And we're here with a world authority on prostate cancer. His name is Dr. Stephen Scionti. It's my pleasure to know him. He's a friend of mine. We met a few years back. And, you know, everybody's always saying how small of a world it is. It turns out that Dr. Scionti, along with one of my good friends who's passed away, Dr. George Suarez, were the pioneers in a treatment called HIFU. It's an ultrasonic prostate cancer removal. There's many people doing it, but not at the level that Dr. Scionti's doing it. I have a good friend, who's a physician as well. He will go unnamed for HIPAA reasons, but he is a very smart individual. And unfortunately, he developed some prostate problems. He did his research and he came back to me and he said, there's 3 guys in the world that have distinguished themselves as really being experts in this field. A guy in London, a guy at UCLA, and a guy right here in Sarasota, and that's Dr. Scionti. He came to us actually from New York University, where he was a professor for a while. But I'm going to let Dr. Scionti talk about his area. But I think we all want to know things like, at what age should we start being screened for prostate cancer? Are there things that make the diagnosis difficult? Are there things that increase your chances of getting prostate cancer? And I know that there's a couple of things that people take when they want to regrow their hair that falsely lower your PSA so you could actually have prostate cancer and not know about it. So I want to know, can you get evaluated by stopping that medicine, and how long do you have to be off of that medicine? But we're going to re-ask these questions as we go along. I'm going to turn it over to Dr. Scionti, and he can start with tell us the incidence of prostate cancer. Is it increasing? Is it decreasing? And at what level should we be screened for it?
Well, Dr. Montesano, thanks for that wonderful introduction. So prostate cancer is the most common solid organ cancer in a man. And, you know, between 1 in 6 and 1 in 8 American men will be diagnosed with prostate cancer in their lifetime. It's a higher incidence in African American men. So it's 1 in 6 in those gentlemen, 1 in 8 across the whole population. So it's the most common thing a urologist will deal with. And now, how do we find it? You know, and who's at risk? Well, let's start with risk. So if there's a positive family history, so if dad had prostate cancer, if a granddad had prostate cancer, a brother, an uncle, these first-degree relatives, the risk increases as the number of first-degree relatives with cancer increases. And so the first thing we always ask, is that are you a high risk person? So if there's a strong family history of prostate cancer, if dad and granddad or a brother have it, you're definitely at higher risk. And so if your race plays a role, our African American gentlemen are at higher risk for prostate cancer. So that affects screening recommendations. So screening is really simple. It's a PSA. It's a blood test. PSA, prostate-specific antigen. It's a chemical made by everybody's prostate. Every man's prostate makes PSA. Now, when that level is elevated, it's a caution. It's a warning sign. It's a yellow light that says, let's look a little further. Starting at age 40, high-risk men need to start at least getting their baseline PSA. Know your PSA. It's a number that every guy should know. So age 40, though, is when it starts for high-risk patients. If you're low risk, no family history, white, non-African American, age 50 is a general time where screening starts.
And how often should you get screened?
Well, depends on what that first PSA comes back at. So if a man is in his 40s, for example, and that PSA is under, say, 1.5, that's a low number. But that man's risk for prostate cancer will be very low. Very low. But if that number's over 1.5 for someone in their mid-40s, we're going to start to look at that PSA every year or two, right? And so that moves you into a category we want to take a closer look. Now at age 50, the number's going to go up a little bit. As we get older, prostate gets bigger, makes a little more PSA normally, so the PSA threshold numbers start to go up a little bit with age, right? The real time we're really focused on this for most men is really age 50 to about age 65 to 70. That's the sweet spot where finding a cancer early makes the greatest difference, right? So, screening has been a little controversial because there is a thought that there was a lot of over-treatment going on. So we go back 20 years ago. A guy had an elevated PSA. He automatically got a biopsy. Some cancer was found. Automatically, he had his prostate removed. And that represented a tremendous epidemic in over-treatment for the disease. A lot of side effects were unnecessary. Today, we're smarter about it. Today, we're a lot smarter. Today, if the PSA is elevated, there's other things we can do to see what that risk is. So, for example, PSA is elevated and we're not sure whether it's a significant thing or not, then it can be repeated. If it's still elevated, then we can get a beautiful study called an MRI of the prostate. That MRI will show exactly what the prostate looks like, how big the prostate is, and if there's an area there that is either suspicious for a tumor or starting to develop a cancer. And then that helps to understand whether a biopsy is necessary. So there's a lot of technology that comes into play here that we didn't have 10 or 15 years ago.
Let me ask you about that MRI. Now, it's not a regular MRI, right? It's an MRI that's coupled with something else that looks at the...
Well, it's the same machine that every radiology center has, but the way that the pictures are done, they're zeroed in on the prostate. And there are different, what they call sequences, different ways to look at the prostate tissue. And what it really requires is a radiologist who's got some experience in reading these things. So the pictures have got to be done correctly, and the radiologist has to have experience reading them. And that's happening more and more. MRIs are not uncommon today for the prostate. It's a very common test.
And what is the MRI looking for? Is it an MRI combined with spectroscopy, or what particularly lights up? When something lights up, what is that lights up? What is?
Yeah, so the technical name of the study is called a multi-parametric MRI of the prostate. So parameters are different things you're looking for, different conditions, right? So the first thing is one series of images looks to see if there's any dark areas in the prostate. That's what's called a T2 image. The next thing the MRI will do is it will look for the movement of water particles through the tissue. So when water movement is restricted, that's called diffusion. And when water particles don't move well, that's called restricted diffusion, and that's a warning sign for cancer. And the third thing the MRI is looking for is blood flow. If there's an asymmetric, abnormal, uneven early blood flow in an area, combined with those other two abnormalities, then that really suggests a high risk for it being a cancer. Because, as tumors grow, they like to make their own blood flow, and that's one of the things that we can see on an MRI.
Now, I know in my field, spine surgery, a lot of people come in getting information and many times misinformation off of the internet. I had to take a course recently on medical information, and it said something like 80% of the information about medicine on the internet was placed there by non-physicians, and 50% is wrong and 50% is right. So let me ask you some of the things. Now, you see an area and you think it needs to be biopsied. I try to be a total physician to my patients, and one of the things I've had family members and patients say, if I get a biopsy and it is cancer, aren't I seeding the cancer? How do you address that when somebody asks you that question?
That's a great question, and to this day, there's no real proof in any of our medical literature that, at least for prostate, a biopsy seeds cancer. But it's been suspected for a lot of years. That conversation is certainly out there. But there's never been any real documentation that occurs. And probably it's because the biopsy techniques today, the needle that's used kind of retracts within a sheath. And the surrounding tissues don't see that core of tissue being removed. Having said that, we still don't want to biopsy people who don't need biopsies. There's some risks to that, with bleeding and things like infection. So, but the seeding is probably not a real issue as far as we know for prostate cancer.
After a man is over 65, if he gets to 65, no cancer was ever detected, and now he's 70 and ends up with a high PSA, what is his risk for prostate cancer at that point in time?
Well, that risk is still there for a man who's 70 or even 75, but there's a lot of things that can make that PSA go up as we get older. The most common thing is the prostate's getting bigger. So as we age, the prostate grows. When the prostate gets bigger, it makes more PSA. So when a man, say 70 years old, has an elevated PSA, it could be from cancer, but it also very likely can be from prostate enlargement or just some inflammation in the prostate. So how do you sort that out? Well, the PSA taken over time can help sort that out. There's different types of blood or urine tests that can help identify risk, but really it's the MRI then. The MRI really then is I think the most accurate way to sort out that risk. So if there's a clear and obvious tumor on MRI, that gentleman is going to go on and need a biopsy. And the biopsy techniques are really different today, by the way. In the old days, which wasn't that long ago, an ultrasound probe would be placed into the rectal area, and a biopsy needle would be directed into 6 or 12 different areas randomly into the prostate. Now, that's like, if you're a fisherman, that's going fishing without a fish finder, right? That's throwing darts at a dartboard with a blindfold on. That doesn't make any sense. When you have MRI, when you have a roadmap the MRI creates, technology exists today. We can create a beautiful map from the MRI, marry it to an ultrasound, and now to do precision targeted biopsies of where that tumor is, instead of just throwing needles into the prostate and hope you hit something or miss something.
I'll use myself as an example. About 30 years ago, I had a borderline elevated PSA. I don't think MRIs were as common back then. And I was a professor at the University of California, Davis. And so I saw the chairman of urology, great guy, great urologist. And we had an informed discussion. We did a biopsy. Well, he did the biopsy, and it came back negative. But, he said, okay, let's just follow this. So I followed it. And about 5 years later, I had moved to Florida, and I had a PSA taken, and it came back 28. I saw 2 urologists, and they freaked out.
Sure.
Quite frankly. And then I saw our friend, George Suarez, and he said, it's impossible for that to represent cancer. Put yourself on some antibiotics for a week and re-study it, which I did, and then it came back normal. But from 28 to normal, I thought that was a big... but do you see that?
Oh, sure we do. If a PSA is elevated, the first we're going to do is let a little bit of time pass, and we're going to repeat that PSA. Mm-hmm. There are false positives. I mean, tend to be laboratory errors. Sure, there can. But inflammation, prostatitis, inflammation in the prostate makes the PSA go up. Even things like sexual activity make the PSA go up. So, a PSA being elevated is not a diagnosis of prostate cancer. It's a caution light. It says, hey, now we got to look a little further. Repeat the PSA. Maybe get some other, blood test or urine test markers, get that MRI, and find out if there's really something there or not.
If I'm going to have my PSA tested, how many days should I abstain from sexual activity before I have the PSA drawn?
Yeah, that's a great question. It's recommended a minimum of 3 days. A minimum of 3 days.
And the other thing is, I have a friend, close friend of mine, and he was losing his hair, and I alluded to that earlier. And he was put on medication for
finasteride, Proscar,
And nobody told him that this could falsely lower the PSA. And I'm not sure how long he was on it for, but he was getting his PSA checked, and they were always coming back normal. And then he had a lesion that was palpable, and they took him off, came back elevated, MRI, biopsied it. Unfortunately, it came back cancer. Do you see that often?
Oh, sure. It's very common.
Why isn't it more well known when they start you on this medication? Why isn't, if that can happen, I would think that somebody would say, hey, we're starting you on this for your hair loss, but you need to know, you need to get your PSA, and once a year you've got to be off of it for X amount of time. And how long do you need to be off of it before you check your PSA?
Well, no. So we know what what the medication does. It basically halves the PSA. So, or if we see a man come in with a PSA on finasteride, on Proscar, we're going to double that value to get the true PSA number. So if the PSA is 3 on that medication, the real PSA is 6. So we don't even need to stop it. That ratio is so precise. That 2-to-1 ratio is so well known. Now, urologists know this, right? And I think a lot of family docs probably know it. Whether hair loss doctors know it or not, I don't know. Right, but it's a very common thing in urology.
That's the group of people that we have to get that information.
Yeah, it's a common thing. That's a common thing. In fact, I was recently doing some board review questions, and that was one of the questions. So it's a very common thing.
Now, one of the things we do in our practice, because I treat a lot of athletes, a lot of fighters, we do IV therapy. I see a lot of victims of car accidents where they have a head injury, and I use IV therapy for that. NAD plus is one of the things that really it's amazing. People come back to me, they've been depressed, they're in a fog, 1 or 2 doses, and so I'm in that realm where I'm doing, and I use peptides and all these other things.
You're in the functional medicine world. Yeah,
yes,
absolutely. Yeah.
So I have a couple of hats that I wear, and one of the things that I do not do, and I do not recommend, is this epidemic of people taking testosterone. Yeah. I've never been for that. I've never been for these guys that want to they have a normal testosterone, but they want to have it even more elevated. And, I tell people, look, there's risks of that. It's not without risks. And one of the risks, I believe, you correct me if I'm wrong, is that it increases your chance of prostate cancer. And I hear so many people that are in that functional medicine realm saying, oh no, these guys that tell you that don't know what they're talking about. It doesn't increase your... Can you address the use of testosterone and how that relates to prostate cancer?
Well, it's a real common clinical scenario we see. And so should a man take testosterone or not? I think it depends on whether he needs it. Mm-hmm. And so to give testosterone to someone with essentially however we define normal, but a normal testosterone level probably isn't going to do much good. But it will increase some risks. It's going to increase some risk for prostate enlargement, for BPH. Prostate's going to grow if there's more testosterone. The real risk, though, for guys who start testosterone replacement, if they don't need it, it's going to suppress the function of the testicle. And over time, the testicle is going to shrink. It's going to get smaller. It's going to get what we call atrophic. And pretty soon, the testicle won't be able to make its own testosterone by itself. So men who are on long-term testosterone replacement essentially are going to end up being on it for life. For a young man, and this is where we worry about the athletes, it will inhibit testicular function and sperm production. So you take a young athlete or someone in the gym, a guy in the gym in his 30s, still wanting to have a family, should not be on testosterone. He's going to be infertile, right? So that's one of the other risks. But how about prostate cancer? There's really it's really been a myth for a lot of years that testosterone by itself just causes cancer. It doesn't do that. There's no good evidence that happens. However, can it make the PSA go up? Yeah, it will. It increases the function of the prostate cells, and they make more of this PSA chemical. So on testosterone replacement, someone needs to be monitored by someone who knows how to interpret PSA, ideally a men's health specialist or a urologist, because as those PSAs go up, you have to be able to evaluate that. Is the PSA going up because it's simply being stimulated by the testosterone rise, or is there an underlying cancer that's been there and now is becoming more notable because the PSA is rising? So if a man needs testosterone, if the T levels are low, if he's got symptoms, he's got a low sex drive, he's lost his energy, his body muscle mass is decreasing, he's getting some osteoporosis, osteopenia, losing some bone mass. He's got these symptoms that go along with low T, and in fact we can document that there's a lower level of testosterone. That man is going to feel a whole lot better if we supplement him. But simply to take it just to, I want to get more muscle mass in the gym, or to take it because, I think I'm going to perform even better sexually, that's probably not going to happen. So the key is if it's necessary, it's safe, if it's monitored, but like any medication, you've got to be smart about it.
One other question, and then we're gonna talk about cancer itself. But I've heard people say that if you're on testosterone for a certain length of time, it makes your body stop producing its natural.
That's correct.
And some people have said then you have to be on it for the rest of your life.
That's right.
And how long, if somebody's on testosterone, for how long does it take where your natural production is suppressed?
A couple of months isn't going to change it, but once you get out beyond really about a year or two, the cells in the testicle, they're called Leydig cells, they begin to, over time, shrivel up. They become atrophic, and that can occur even with just up to 2 years of testosterone usage. By the time you get to someone that's been on it for 5 or 10 years, and their testicles aren't going to respond. They're not going to make their own testosterone very well.
Let's move on to the individual. He's been diagnosed, and he's just been told that he has prostate cancer. There's no metastatic lesions. It's within the prostate itself. What are the options for treatment?
Well, so there's no perfect one way to treat prostate cancer. The traditional approaches, and what I learned, back in the 80s as a young surgeon, was that the only way we can really cure prostate cancer was a prostatectomy operation to remove the entire prostate. And of course, radiation became better over the years. And so the two most standard recommendations patients will hear are prostatectomy. Now it's done with robotic technique today, so the incisions are smaller, but it's the same operation that I learned 35, 40 years ago, or some type of radiation energy. Here's the problem. As good as the surgery's gotten and as much improvement as there's been in radiation therapy techniques, we still can't get over the two major problems we see with our traditional therapies. There's a very high risk of significant sexual dysfunction, even in expert hands. And there's a certain number of patients that are going to be incontinent. They're going to leak urine. They're going to require a pad or a diaper. And so I'll tell you a story what changed my mind about this. When I finished my training in 1990, and I was in the military as a military surgeon, we did a ton of prostatectomies. That's what I was most proud of, is how good I could do that operation. And went into practice after getting out of the service. And after about 10 years into practice, I did a radical prostatectomy on a gentleman that I knew. He was a personal friend in our community, very, very well respected guy. My partner at the time was a super experienced surgeon who was trained by the guru, Dr. Patrick Walsh at Hopkins. So I did an operation on this gentleman, and it was you ever do an operation, you said, oh my God, that is beautiful. It is textbook. You look at it and say, it's a work of art. I don't think I could have done it any better. That was the case with this gentleman. Here's the problem. He never got dry. He never got dry. At 3 months out, okay, let's give it another month. And after 6 or 8 months, he was still in a diaper. We ended up having to do an operation called an artificial urinary sphincter on him. But I critically looked at that and I said, how can one do a textbook, beautiful operation and still have a patient that's just wet? And you go into the literature and you see that that's not uncommon. If you survey patients directly, if you ask the doctor, oh, everyone's done great. But if you go back and you actually measure patients' continence, as many as 1 in 4 men still require, even a year or 2 after their operation, still require some sort of pad protection. Now, the sexual side's far worse because unless someone has perfect erections at, say, age 50, there's going to be some decrease. But for most men, by the time they're in their mid-50s, 60s, there's a little bit of decrease. They're not like teenagers anymore, okay? And we do that procedure, that prostatectomy procedure, even with nerve sparing, even with robotic technique, sexual function will never, ever be the same again, ever. There's going to be a definite loss in erectile abilities. There'll be some penile length shortening, and orgasmic function is totally gone by definition because there's no prostate. There's no ejaculation. So here's what we tell guys. PSA's elevated. We're going to find a cancer. You got to have a prostatectomy. But what sometimes isn't real clear is your life is going to change. You got a risk. You're going to be in the gym. You're going to be exercising. You're going to have a pad. You're going to lose erectile function or some degree of it such that it's never normal again. So that's the problem with our traditional techniques. I recognize that after that experience I told you back, over 25 years ago, realized there had to be a better way. So began to explore a concept called focal therapy. Focal therapy means that if we can find a cancer when it's in a small part of the prostate, we can use high-tech approaches to target energy to the tumor region and not destroy the nerves, not destroy the urinary channel, not destroy the sphincter, and then get that advantage of knocking out the tumor and maintaining function, maintaining normalcy, not destroying a guy's life. That's what I spent the last 20 years doing, is developing those techniques. And that's where I met my friend George Suarez. I met him down in the Dominican Republic, 2004. That was 21 years ago. And was introduced to a new technology that was just being developed called high-intensity focused ultrasound. Now, it was pretty primitive in those days. But today, that technology allows me to take an MRI image, marry an MRI to an ultrasound, find where the tumor region is, and if a man is fortunate enough to have cancer in just a region, if he's got focal prostate cancer, I can do a focal procedure, an hour and a half in and out of the hospital. I did 2 of those this morning. We can knock the tumor out, and a week later, he's going to be catheter-free, urinating normally, and be able to have relations again. So that's a major game changer, major, over what we had 20-some-odd years ago. But it's a paradigm shift.
Wow.
It's a paradigm shift. It's a whole different way of thinking about this disease.
So what I understand is it's not for everyone, and I like to use, I explain things in terms of circles and circles fitting in circles.
Right.
So the old techniques are and were, let's use past tense, applicable for all cancers. This new technique is only applicable for focal cancers. So not everybody who has a diagnosis of prostate cancer is lucky enough to be a candidate for this procedure.
That's right.
Okay, let's compare apples with apples. You've got a focal lesion that can be treated with robotic prostatectomy, that can be treated with radiation, that can be treated with HIFU. Mm-hmm. Give me the statistics on sexual dysfunction, because I think as a man and talking to most men, that's the thing that they're most concerned about. Everybody's concerned about wedding, but the one they're really concerned about is sexual function. So what's the % chance of loss of sexual function, robotic, radiation, HIFU?
That's a great question. And as usual, we can go back to the science to answer that. Okay. There is a recent study that has just been completed. It comes out of Europe, but is what's called a randomized prospective trial. Randomized means men come into the trial and they're assigned to either prostatectomy or to focal therapy. And this study was done in Europe. And then they were followed for a series of years. And the things that were looked at is, from a cancer standpoint, how well did the focal therapy procedure, and HIFU is what was used, compared to prostatectomy in terms of recurrence or the need for secondary therapy? The answer is they were equivalent. Okay, so there was no penalty to having a focal therapy in the right patient. But what was different? What was different was the side effects. In the prostatectomy group of patients, over half of those men, even with medications, their erections were still not satisfactory for successful intercourse. In the focal therapy group of patients, 90% of men were able to resume erectile function that was very satisfactory. That's a huge difference. It's almost a 2-to-1 difference. And when you go to continence, okay, the risk of incontinence or leakage is extremely low with the focal therapy because the urethra, the sphincter mechanism, the valve isn't impacted. And so I will tell you, in my practice, I cannot remember the last time I've had a patient with a pad or a diaper. It's so rare we don't see it. In our prostatectomy patients, it's 15 to 20% of men with some degree of leakage. Sometimes it's minor. But if you're in the gym wearing a pad and that pad gets wet at the end of your workout, that's a problem. If you're having relations and you're physically active having sex and you're leaking in the bed, that's a problem. So, this is a major, major difference. From a quality of life difference, I will say, then I'll say this to the world, there is no comparison. And I don't understand why, a man would have a prostatectomy if he didn't need it, if he can have a focal therapy. And the only reason is many times he doesn't know that is even available. Because as you know, in many parts of the country, unless there's someone who's locally experienced with that, a lot of men won't even know about it. Their doctor will say, hey, we should do a prostatectomy. This is what we do. This is what we're good at. And they'll go off and they'll have that procedure. And so this is a game changer. This is really a game changer in the right patient.
As you're describing this study that came out of Europe, I had to think about how can you do such a study? What's the ethics of that when you know that there's this treatment out there that, at least from what I know about it, and once again, we're talking 4 focal lesions, seems so much superior. Two things. How do you get that study done?
Yeah.
What kind of informed consent?
That's hard to do in the United States.
Yeah. And in terms of treatment here, are there situations where somebody has a focal lesion and they're not given the option of HIFU therapy?
Oh, it's common. It's common. It's very common. Most of the patients I see in my practice, they come from all over the world. By the time they come to me, they've learned about it from their own research. It's rare that they're diagnosing urologist, unless they personally perform the procedure, is even going to tell them about these things. And that's the sad thing, right? Wow. And so what I would say to patients is, do your research. If you've got a cancer diagnosis, particularly prostate cancer diagnosis, take the time, take a deep breath. You've got time to make a decision. Do your research, learn your options, find where people are experienced with these different techniques, and take the time and get a consultation and learn what your options are. It's all about choices. It's not that surgery is bad. It's not that there aren't patients who really require it, but it's clear that not everyone needs surgery. It's clear that there are alternatives. And if you're a candidate for a more precision, targeted treatment that preserves quality of life, who wouldn't want to do that?
So, last question. As a physician and as somebody who gets screened, has to be screened for prostate, I told you I recently had a PSA that came back 4.1. I said, I need to repeat this. So I put myself on antibiotics for about 5 days, went back in, it came back 3.3. But I hear all the time people tell me, hey, I was diagnosed with prostate cancer. It's beyond the capsule. I was told HIFU's not a choice. But you know what? My sexual life is too important to me, and I'm going to have to make an informed discussion as to whether I can live or can't live with that in my life. And the doctor told me, look, if I do a radical prostatectomy, I think you have a X% chance of living so long. If I don't, then, I can't tell you how long you're going to live for. And I've had patients say, okay, thank you for telling me that. I want focal HIFU therapy, and what I'm going to do is I want the left side done, and then 6 months later I'm going to come back and get the right side done. I mean, here you have a situation where the patient is really pushing their surgeon, and the surgeon may not agree with it, but the option is that the patient says, well, then I don't want treatment.
This goes back to the concept that we use today called shared decision making, right? It's not like when we were young doctors where the doctor said, okay, patient, this is what you're going to do. That's your only option. If you don't like it, too bad. This is what we're going to do. That really, I don't think happens very much anymore, and it really shouldn't happen. Today, it's about shared decision making. It's having a conversation with that treating physician and saying, and the doctor, and so when I talk to a patient, okay, here are your options. Here's the pros and cons of the different approaches. But the most important thing I'm going to say is to my patients, what's important to you? What's important to you? How important is it to you to maintain, if erectile function is a really important part of your life, then we've got to take that into consideration. We have to design a treatment that's going to preserve that. Now, it may be at the cost of a higher recurrence rate, which means we may need to do additional therapy in the future. But if I can buy that man 5 to 10 years of normal sexual function, that might be something that he might want to do. That's really not my decision, right? That's a shared decision that I'm going to make with my patient, right? Patient gets a choice. They're the one who's going to live with the consequences of what we do, and everyone values things differently, right? Some guys, they're going to value oncologic or cancer control. Number one, I don't care what the side effects are. I want the greatest chance that I'll never deal with this again. And that's a different patient than might say, I've got to maintain my erectile function. It's the most important part of my life. Now, at the same time, if that's a crazy thing to do, I've got to tell the patient that. But ultimately, it's a shared decision that we're going to make together.
Last question. There's one topic we didn't touch on, and that's hormonal replacement or hormonal therapy.
Yeah.
How does that play in? Who's a candidate for? That's an adjunct that's used with these others, but not to replace these others.
So you're talking about for prostate cancer treatment?
Yes.
Okay, so hormonal therapy for prostate cancer treatment really refers to suppressing testosterone, knocking testosterone out with drugs. And it's an adjunct for advanced disease. So for a man that's got locally confined, focal disease, it's not something that ever comes into play. For a man that comes in with a diagnosis of an advanced cancer that's already, for example, in his lymph node or his bones, it's going to be a part of the treatment. Suppressing testosterone does slow the cancer growth. And in fact, there's some evidence that it may, in fact, cause some death of some of these cancer cells as well long term. So it comes into play for more advanced disease. But for the guys that we see today who are finding the cancer early in a regional or in a focal area, they're going to get through this without having to suppress testosterone at all. They're going to maintain normal testosterone levels. So I think that's all about, it's all about giving men options. And, yes, we have HIFU. There's other types of focal therapies we use as well that are highly effective. So with different tools I have for focal therapy, but the concept is we got to do precise diagnosis. We got to understand where the cancer is, how large it is, what the tumor's near, and if it's a regional tumor, a focal tumor. If it is, we can develop a program to knock that area out, getting the right balance between cancer control and keeping that man whole, maintaining his life, because that's what guys want. No one wants cancer untreated, but no one wants to go through life, certainly in a diaper, and certainly losing an important aspect of their life, their sexual abilities. So it's about using technology today to offer, choices to patients. And I think that's what drives me. That's what I'm doing now for the last 20 years.
Wow. Well, listen, thank you very much for giving your time to us today. I think you've been very informative. And that's another session of Black Belt Lifestyle. So until next time, stay healthy out there. Get your prostate checked. Get it examined. Get your PSA level drawn. We'll see you next time.